The major points that I'd like to review with you today include the increased health risks that patients with IBD commonly have, prevention strategies to address these health risks, the importance of collaboration with your patient's primary cares, common immunizations that we should be discussing and recommending to our patients, and important other screenings for your patients, including colorectal cancer screening, bone health screening, cervical cancer screening, mental health screening, and smoking screening, nutritional assessments, and assessing for latent infections. Many patients with IBD are on immunosuppressive medications, such as corticosteroids, thiopurines, methotrexate, small molecules, or biologic agents, which make them not only at an increased risk for the development of opportunistic infections and malignancies, but they're also more at risk for having a more severe and complicated course if they do get these infections. Many patients with IBD are also at an increased risk for certain malignancies, which can include colon cancer, cervical cancer, and skin cancer. There are multiple types of prevention, but the two that we're mostly going to focus on today are primary prevention and secondary prevention. Primary prevention is really aimed at preventing disease, and we usually do this through vaccination. Secondary is aimed more at detecting disease early, and we utilize screenings for that. It's also vital that when you are seeing patients and implementing health maintenance strategies that you involve the patient's primary care. Studies have shown that rates of preventative care for patients with IBD are lower than that of the general population. IBD patients have also been noted to have poor uptake of routine vaccinations. This is likely due to several reasons, including that primary care providers may be less comfortable making recommendations about immunizations, particularly for patients that are immunosuppressed. They just may have a lack of knowledge regarding which ones are required and what screenings are appropriate for patients with IBD. Many patients with IBD also don't have a primary care and view their IBD providers as their primary care. We really need to be encouraging these patients to establish with a primary care and assist them as needed and as possible. Make sure to collaborate with the primary care to review the patient's immunization history and help your patient obtain all appropriate immunizations. It is so beneficial to have vaccines available in clinic and the ability to administer them right at patients' appointments. It's reasonable that vaccination recommendations are the responsibility of the treating GI team, but the actual delivery and administration of these vaccines may be more of a shared responsibility. So we need to try to concisely communicate specific recommendations to the primary care. It can be helpful to try giving the patient written recommendations that they can physically bring to their primary care. Some providers are also able to share recommendations by their electronic medical record. I'll go over this checklist step by step, and the link to it is at the bottom of the next few slides. This is the health maintenance checklist for adults with IBD that was created by the CCF. I think this checklist is a great tool. You can print it out and have a copy right in your clinic rooms, and you can go over it step by step with your patients at their visits. I definitely recommend using it as a tool, but you should really also make sure to meet with your team, decide what your team wants to prioritize and implement, as actual practice and recommendations can vary from provider to provider, as well as based on the individual patient's history and their medication regimen. So these are more of the vaccinations that I'm going to go over with you. So immunizations are key to preventing infection or reducing the severity of infection. They are important for any patient with a chronic illness, but especially those diseases that are immune-mediated, such as IBD. Providers should follow the standard immunization schedule for adults and consider additional immunizations based on individual patient risk factor, which typically we're thinking about their specific medications. There's no convincing evidence that IBD activity is going to be exacerbated by vaccination. So an important definition that we need to keep in mind is the definition of systemic immunosuppression. This is the definition utilized in the CCF health maintenance recommendations. Just briefly summarizing it, it's patients that are on prednisone at least 20 milligrams or more for 14 days or longer, thiopurines, methotrexate, cyclosporine, tacro, anti-TNFs, IL-12 and 23 inhibitors, S1Ps, and JAKs. The majority of vaccinations that you'll see recommended for your patients are safe. We only have to avoid live vaccines. If a live vaccine is needed, you should try to make sure it's administered at least 4 weeks before you start any immunosuppression. And you definitely have to avoid it within 2 weeks of starting immunosuppression. If the patient is already immunosuppressed, you have to stop it for at least 3 months before you can give any live vaccines. That really does not apply to corticosteroids, though. We try to have patients off of them for at least 1 month if possible. The common live vaccines include varicella, MMR, and the live influenza vaccine. Several travel vaccines are live vaccines. The one that I most frequently see recommended to my patients is yellow fever. We also counsel any pregnant immunosuppressed women that their infant should not receive any live vaccines, just like they cannot receive any live vaccines. And so we tell mothers that they need to skip rotavirus vaccination for their baby. The package insert for Entyvio actually states that patients on this may receive live vaccines if the benefits outweigh the risks. In my practice, we're not advising patients that are on vedolizumab to receive any live vaccinations. Patients with IBD have been shown to have a higher risk for getting the flu compared to individuals without IBD. Patients with IBD are also at higher risk for hospitalization due to the flu. Immunosuppressed IBD patients are at increased risk for getting influenza and having worse outcomes, which can include hospitalization and superimposed pneumonia. That's why it is so important that we're vaccinating our patients for influenza. For most patients who only need 1 dose of the flu vaccine, you should vaccinate them during September or October. But if you don't get them in September, October, continue throughout the season as long as the influenza viruses are circulating. For most adults, particularly those 65 and older and pregnant persons in the first or second trimester, you really want to avoid vaccinating during July and August unless you don't think that you're going to be able to vaccinate in September, October, or later in the season. Those on anti-TNF monotherapy, we want to receive the high dose flu vaccine, just like adults 65 and older should receive the high dose. And any immunosuppressed patients, they cannot receive the live vaccine, which is the nasal influenza. We have seen that when patients are on a combination of a thiopurine and anti-TNF, their serologic response to vaccination is impaired, but even a blunted response is thought to be beneficial. So we're still absolutely recommending vaccination to that population. Patients with IBD are also at increased risk for developing pneumococcal pneumonia compared to the general population. As with all vaccines should be administered early on after diagnosis of IBD and preferably before you initiate immunosuppression. And that's just an effort to try and avoid that blunted immune response. But of course, you want to vaccinate patients that are already on a biologic or immunosuppressed. So for pneumococcal vaccination, we are really at this point just administering PCV20, the Prevnar 20. And if you're looking at this chart, we're following option A. You certainly can administer some of the other types of pneumonia vaccination, but we found it to be simpler to just have Prevnar 20 in our clinic and administer that one. Patients with IBD are at increased risk for development of herpes zoster, which is also known as shingles, compared to the general population. This is notably increased further for patients who are on immunosuppression and especially the JAKs. In the general population and immunocompetent adults 50 and older, the CDC recommends that they receive 2 doses of Shingrix separated by 2 to 6 months. And this is recommended whether or not the patient has had shingles in the past or has received Zostavax in the past. We also do not need to screen for evidence of prior varicella. In July 2021, the FDA approved Shingrix for the prevention of herpes zoster in adults 18 and older who are or will be at an increased risk of shingles because of immunosuppression. So some are suggesting that we should consider vaccinating any patients 40 and older that have a history of having shingles, those who have had repeated courses of steroids, any patients on combination therapy and receiving steroids, and then all patients on JAK inhibitors. There is no specific amount of time you need to wait before administering Shingrix to patients who have had herpes zoster. However, you should not give Shingrix to patients who are experiencing an acute episode of herpes zoster. The vaccine series does not need to be restarted if more than 6 months have elapsed since the first dose. You can give Shingrix to patients who have previously had chickenpox vaccination. And you also should give it to people who have received Zostavax. We know that Zostavax effectiveness has waned substantially with time. We're really not giving that vaccination anymore. And so if people receive Zostavax, their protection has also significantly decreased. At this point, there are no recommendations for booster doses of Shingrix, regardless at what age patients initially receive it. That, of course, may change with time and as we are able to see how the effectiveness wanes with time. Hepatitis B vaccination is also recommended for adults aged 19 to 59 and those adults 60 and older that have risk factors for hepatitis B. Adults 60 and older without known risk factors for hepatitis B may also receive the vaccination, and that is something that you would consider shared decision-making. Given the importance of hepatitis B infection in IBD patients, we really should be checking to make sure that patients are immunized appropriately. If they have hepatitis B and that is reactivated, that has had very serious consequences for our patients. You are recommended to check for hepatitis B infection prior to starting an anti-TNF particularly. In healthy individuals, protective antibody concentrations after the primary 3-dose hepatitis B vaccine rates is greater than 95%. But our IBD patients have efficacy rates from the vaccine series that are between 33 to 76%, so it's significantly decreased. Typically, you don't check healthy individuals after they complete the series to see if they're immune, but any immunocompromised patients should have hepatitis B surface antibody levels checked 1 to 3 months after they complete the vaccination series. There are currently 5 FDA-approved Hep B vaccines for adults 18 and older. Heplisav is the only Hep B vaccination that's offered as a 2-dose series. So you can complete that one in 1 month compared to the other ones require at least 6 months to complete. We also recommend following the CDC guidelines regarding COVID-19 vaccination. Being on immune therapies for IBD may increase the risk for some viral infections, but we really have seen there's an international registry of IBD patients who have gotten COVID-19. We're not finding that there's any increased risk for our patients in contracting COVID-19 for any patients who are on our standard IBD therapies. Our IBD patients who do get infected and develop COVID-19 have been seen to recover just like the general population. HPV can cause several types of cancer, including cervical, penile, anal, and some oropharyngeal cancers. Patients with IBD who are receiving immunosuppression are at a 30% increased risk for cervical neoplasia compared to the general population. This vaccination is routinely given to pediatric patients, but it's also recommended for adults through age 26 if they were not adequately vaccinated when they were younger. Using shared decision-making, you may also determine that it's appropriate to vaccinate older adults, those 27 to 45, who are likely to have a new sexual partner. For RSV, we are just at this point recommending RSV vaccination to our patients that are 60 years and older. At this time, we're not recommending that this be given earlier to any younger patients based on their immunosuppression. We also recommend following CDC guidelines for Tdap vaccination for all IBD patients. So that includes that any adult who has never received Tdap should get a single dose of Tdap that can be given at any time, regardless of when they last got TD. And then you need to follow this by either a TD or Tdap booster every 10 years. MMR vaccination is recommended for IBD patients who are determined to be not immune to MMR. However, patients currently on systemic immunosuppression cannot receive this vaccination. If an immune status is uncertain, you should obtain the immunization history, but it's not recommended to routinely check IgG antibody titers. Varicella vaccination is recommended for IBD patients who have not received 2 doses of vaccination. Patients currently on systemic immunosuppressive therapy cannot receive this vaccine. They also do not recommend serology to check if patients are immune to varicella. The next part of this checklist reviews some recommended cancer screenings and other health maintenance screenings, which I'll review more in depth. Patients with an 8 or more year history of UC, which is excluding just ulcerative proctitis and Crohn's colitis that involves more than 1/3 of their colon, are at an increased risk for colon cancer. Surveillance for colon cancer should begin within 1 to 2 years after an initial screening colonoscopy. And if that is negative, surveillance colonoscopies are recommended every 1 to 3 years. Patients with UC that also have primary sclerosing cholangitis, also known as PSC, should have an annual colonoscopy from the time of their PSC diagnosis because they have a significantly increased risk of colon cancer. Cervical cancer is caused by persistent infection with oncogenic HPV. Known factors associated with an increased risk of cancer include cigarette smoking and a compromised immune system. Although vaccination against HPV remains a recommendation for women aged 9 to 26, most females would have been exposed to HPV by the time they are vaccinated, so regular screening remains the best approach to protect women from cervical cancer. The American College of Obstetricians and Gynecologists and the CDC both recommend annual screening for women who have a history of chronic immunosuppression. In older patients between 27 and 45, the ACIP recommends individualizing these scenarios, and they encourage shared clinical decision-making between the patient and the provider based on their risk of HPV. Patients with IBD, regardless of immunosuppression, are known to be at an increased risk for the development of skin cancers, both melanoma and non-melanoma. Non-melanoma skin cancer is particularly associated with the past or current use of thiopurines, and melanoma is more associated with the past or current use of anti-TNFs. We suggest that all IBD patients follow a program of sun protection and skin dermatological surveillance, which takes into account their specific risk factors and family history. And we recommend sunscreen protection for all patients with IBD. For mental health, we know that anxiety and depression are more prevalent among patients with IBD compared to the general population. A review found that anxiety was present in 19% of IBD patients compared to 9.6% of patients without IBD. Depression was found in 21.2% with IBD versus only 13.4% in patients without IBD. They also notably found just as much depression in patients with inactive disease as those with active disease. So for this, we recommend that you complete annual depression and anxiety screening as well as at baseline when you're establishing with the patient. If any of these screens are positive, you should refer a patient to counseling or therapy. Regarding bone health, the prevalence of osteoporosis in IBD is also increased. Males and females are actually at a similar risk. The biggest risk factor for this is corticosteroid use. Even in newly diagnosed patients with IBD, and before any medications are started, we know that the prevalence of osteoporosis in IBD patients is elevated. It's thought that some of this may be related to low bone mass, medications, vitamin D, malabsorption, any dietary restrictions that patients may have if they're not following a balanced, nutritious diet. There are also risk factors include sedentary lifestyle, being underweight, smoking, and then low intake of calcium and vitamin D. All patients with IBD, regardless of their disease subtype, should be encouraged to stop smoking due to the negative effect of tobacco on their general well-being and the increased risk for malignancies, including lung and colon cancer. For Crohn's disease, there are data to suggest that smoking is associated with the development of disease progression, and then poorer medical and surgical outcomes. Data has shown that smoking may have a favorable protective effect on the development of UC. We still are not going to recommend smoking though, and Crohn's is actually very negatively affected by tobacco. The use of tobacco increases the risk for development of Crohn's, but smokers tend to develop more complications, including strictures, and they tend to need more surgical resections. Additionally, smoking has actually been identified as the only modifiable risk factor for postoperative recurrence of Crohn's disease. There have been reports also showing that patients that smoke, regardless of IBD subtype, have increased prevalence of joint and skin manifestations. For infections, it's recommended that you screen patients with IBD that are starting an anti-TNF, JAKs, or IL-12 and 23 inhibitors for any latent infections such as hepatitis B and tuberculosis. And then nutritional deficiencies was spoken a lot about earlier, but just as a reminder, you should also be screening your patients for any nutritional deficiencies at least annually and then as needed with flares. These are some of the health resources that I find very, very helpful. The first one is the CCF that I base most of these recommendations off of. There's also a link to Cornerstones that has a similar IBD checklist. And then the CDC adult immunization schedule. I am constantly printing this out. And if I have a pharmacy like refusing to give Shingrix vaccination to one of my patients because of their age, I print out these recommendations and I give them to people to support the appropriate vaccination.